If you've ever stepped into an intensive care unit as a junior clinician, walked right up to a mechanical ventilator, and suddenly felt your own heart rate spike higher than your patient's just from looking at that screen, well, you are absolutely not alone. Seriously, all those numbers, waveforms, and flashing alarms, it can feel completely overwhelming. But in this explainer, we're going to change that. Our goal today is to take that chaotic screen and make it visual, logical, and actually relatable. By the end of this, you won't just be memorizing random numbers, you're going to see the actual anatomy of the mechanical breath.
So when you stare down that screen, you're usually confronting these 9 core settings: VO2, PEEP, tidal volume, minute volume, respiratory rate, inspiratory time, IE ratio, peak pressure, and plateau pressure. I know, it's a pretty intimidating list. It literally looks like an alphabet soup of respiratory mechanics. But don't worry, we are going to break these down into super simple, manageable pieces using a basic analogy that will make these 9 settings incredibly easy to remember.
To keep us from getting bogged down, we've grouped these into 5 functional buckets. 1. The basics of the breath. 2. Keeping lungs open. 3. Timing is everything. 4. Understanding ventilator pressures. And 5. The danger of auto-PEEP. We'll use a really simple balloon analogy to guide us through every single step. Let's dive in.
All right, Section 1, the basics of the breath, specifically FiO2 and tidal volume. Before we get into all the complex mechanics, we have to decide on the fundamental ingredients of our mechanical breath.
First up, the machine basically asks, how much oxygen is in the air I'm giving you? That is your FiO2, or fraction of inspired oxygen. Just for a little context, the room air that you and I are breathing right now is about 21% oxygen. But a ventilator, it can crank that concentration all the way up to 100%. FiO2 is your primary, baseline tool when a patient's oxygenation is inadequate. Adjusting the FiO2 is almost always one of the very first levers we pull.
Next is tidal volume, or VT. If FiO2 is what we're giving, tidal volume is how much. Think back to our metaphorical balloon. This is the specific volume of air we push into it with every single cycle. For instance, exactly 500 milliliters in, 500 milliliters out. That right there is your tidal volume.
Moving on to Section 2, keeping lungs open with PEEP. What actually happens when the machine stops pushing air in?
So PEEP stands for positive end expiratory pressure. When the patient exhales, the ventilator doesn't just let the pressure in the lungs fall completely to zero. Instead, it maintains this baseline level of pressure. Here is a brilliant little memory trick from our source material. Think of PEEP as prevents end expiration from becoming completely empty. It's that underlying pressure holding all those tiny air sacs in the lungs open. Without PEEP, a normal balloon collapses and deflates almost entirely after you blow it up. But with PEEP, the balloon stays partly open at the end of expiration. By keeping those tiny lung units slightly inflated, PEEP maintains alveolar recruitment. It keeps them open and ready for action, which dramatically improves oxygenation. Think about it. You don't have to force a totally collapsed balloon open with every single breath, which saves a massive amount of energy and prevents further lung damage.
Okay, Section 3, timing is everything. Rate, time, and ratio. Now we're moving away from static volumes and getting into the dynamic, rhythmic side of ventilation. Let's start with respiratory rate. This is simply how many breaths the machine delivers per minute, say 12 breaths a minute. When you combine this with the tidal volume we just talked about, you get a super crucial metric called minute ventilation. The formula is beautifully simple. Minute ventilation equals tidal volume multiplied by the respiratory rate. If you increase the rate, you generally increase that minute ventilation, which helps clear more carbon dioxide from the body. But look, time isn't just about how often we breathe. It's also about how fast we deliver each individual breath. That's your inspiratory time, or TI. Going back to our balloon, inspiratory time is quite simply how long you spend blowing it up. A short TI is like a quick, rapid puff of air, while a long TI is a slow, sustained blow. It's the exact same volume of air, sure, but the speed at which you deliver it completely changes the flow dynamics. Which brings us to the relationship between breathing in and breathing out, the IE ratio. Normally, this ratio is 1 to 2. That means inspiration takes up 1 part of time and expiration takes 2 parts. You spend twice as long exhaling as you do inhaling. And this ratio, it's vital. For patients dealing with obstructive diseases, like severe asthma or COPD, giving them even more time for expiration, maybe stretching it to a 1 to 3 or 1 to 4 ratio, can be absolutely critical to prevent air from getting dangerously trapped in their lungs.
Part 4, understanding ventilator pressures, peak versus plateau. The machine is doing the work, but we need to keep a close eye on the physical forces inside the airways.
So the crucial takeaway here is this sharp contrast between peak pressure and plateau pressure. Peak pressure, or peak, is the absolute maximum pressure measured while air is actively moving into the lungs. It represents the total resistance of the airways plus the stiffness of the lungs. Now, plateau pressure, or P-plat, is an entirely different beast. You measure this by applying an inspiratory hold. The air stops moving completely. Because there is zero flow, plateau pressure strips away all that airway resistance and purely reflects the elastic pressure, or the stiffness, of the lung and chest wall itself. It's moving air versus paused air, resistance versus elasticity. Understanding that distinction allows us to act like clinical detectives. Imagine standing at the bedside. Suddenly, the ventilator starts alarming. You check the screen, and the peak pressure has spiked dramatically. But you check the plateau pressure, and it's completely normal. What if peak rises completely on its own? What is that telling you about your patient?
Well, since plateau pressure is normal, you instantly know the lung tissue itself hasn't suddenly turned stiff. The problem is isolated to the air that's actively moving. It is a resistance problem. So you immediately start running through your real-world troubleshooting steps. Is the breathing tube blocked? Are there thick secretions we need to suction? Is the patient having a sudden bronchospasm, kind of like an asthma attack? Or is there simply a physical kink in the ventilator tubing? Our rising peak pressure points you directly to a flow issue.
Finally, Section 5, the danger of auto-PEEP, or what happens when breaths compound. This is exactly what occurs when flow issues and timing issues crash into each other.
Here is where things can get seriously dangerous. Breath 1 goes in, but before expiration can actually finish and return to baseline, breath 2 is delivered. More air enters. Then breath 3 hits, again way before expiration is complete. The air is actively stacking inside the patient. Their lung is turning into a balloon that's being blown up more and more without ever being allowed to fully deflate. As our source material explicitly states, when air gets trapped like this, that's dynamic hyperinflation, or intrinsic PEEP, commonly called auto-PEEP. Why does this happen? Well, usually it's because there simply isn't enough time to exhale. And this is exactly why indiscriminately cranking up a patient's respiratory rate, especially in someone with severe obstructive disease like COPD, can make things terribly, terribly worse. You are robbing them of the expiratory time they desperately need, forcing their lungs to hyperinflate. Which leaves us with this final, vital question to ask yourself the very next time you're adjusting those complex settings on an ICU screen. Are you giving your patient's lungs enough time to completely exhale? By visualizing the balloon, understanding the volumes, the active flow, and the quiet pauses, you're no longer just reacting to random numbers on a monitor. You are actively protecting their lungs. I really hope you take this new visual understanding straight into your next shift. Thanks for joining me on this explainer. Keep learning out.